and Clinical Care NCP book and Nutrition in Long Distance and Transplant. She contributed to the transplant book New Life, New Beginnings in 2025, which is her latest publication. And she's published extensively at both national and international journals. Dr. Sandhya has Joseph Lister Award in 2015 for the gestational diabetes research, and she has an Excellence in Medical Nutrition Practice IAP and Quality Award, and multiple other awards for papers presented at IDA national conferences. And not just that, she's featured in print media for nutrition awareness many times. Thank you so much, Dr. Sandhya, for being with us here today, and we are looking for your
Thank you,
expertise.
Dipti, for those kind words.
You're very welcome. And I also would like to welcome Ms. Esther for today's meeting. Thank you, Esther, for always being there and guiding these participants. We will go ahead and get started. Like I said, we're going to get started with Ms. Benita Jayasiman's presentation. Sai, I would like you to share the screen for her. If the jury members can have their evaluation forms ready, we can go ahead and get started. So all the participants, you are going to have about 15 minutes for your presentation, 12 minutes for your actual presentation, and we'll have 3 minutes for question and answers. So please plan your slides accordingly, and please progress your presentation accordingly, so you have enough time to present everything that you have prepared for, and also to get a couple questions from the presenters. And before we begin, I would like to also announce that we are going to have a quiz contest today, and we will be giving certificates out to the winners. So what we will do is we will do 3 presentations depending on the time, 2 or 3 presentations, and we will have a very quick quiz contest with couple questions. And our team member Raju is going to conduct the quiz, and at the end of the session, we are going to give the certificates out to the winners. So please pay attention, everybody. And if you have any questions, please leave them in the chat, and we will get back to you guys. So over to you, Benita. Sai, please share the screen.
Okay, ma'am.
Benita, it's all yours, and your time starts now. I'll remind you at 10 minutes and at 11 minutes. So please plan your presentation accordingly. Thank you.
Okay, ma'am. Okay. No. So good afternoon to everyone. So myself, Benita, clinical dietitian working in Aster City, Kochi. So first of all, I am grateful for the opportunity to present my case in the gathered occasion. So coming to my case on the topic burns. So burns is actually a wound caused by an exogenous agent leading to cognitive necrosis of the tissue. So occurred from the contact of excessive heat over the skin, causing the tissue damage and resulting in scarring. So coming to my, can you like move the slide? Yeah. Okay. So my patient's history. So Miss S. Sorry. The second slide. The second, yeah, that's it. Okay. So my patient S, 62-year-old female. To the emergency department with the complaint of her burning waist at her residence. So it was deep dermal to thickness burns. Using a rule of 9, the burn was classified under like 9% in the upper right upper limb, and 4.5% in the left upper limb, 9% in anterior trunk, 0.5% in abdomen, 5% in back and parapanel area, and 4% right thigh, and 4.5% in face and neck. So total burn surface area for the patient was 45%. So patient had a medical history of diabetic, but she was not on any medication, and past surgical history was nil. So procedure undergone by the patient was collagen application, BioBrain application, and bilateral upper limb exerotomy. So collagen application and BioBrain application is basic second and big bond, that is actually osphilic, which will reduce the fluid loss, and it can be peeled on within 5 to 14 days. So can you so coming to the anthropometric measurement of the patient. So usual body weight for the patient was 81 kg, which indicated the BMI as obese. So IBW percentage was above 120 percentage. So the adjustable body weight 61
Vinita, your voice is not audible. Is it audible for everyone else?
No, we've lost her
Yeah.
voice in between.
Yes. Vinita, your voice is not audible. Vinita, Vinita, your voice isn't audible. Can you hear us, Vinita? Sai, can you please check with her and see what's happening on her end?
Okay.
Hello.
Yeah,
Am I
you're having some internet issues, looks like, Benita. Your voice wasn't audible at all.
Okay, I'm sorry. Am I audible now?
Yeah, this is much better. Please go ahead.
Okay. Yeah. I know till when I was audible.
Just go back for to the previous slide, please. Yeah, I think this slide is fine. You can just go a little bit further up and then just start it again.
Okay, fine. I'll just start with the history again. So my
Yeah,
patient,
please.
62-year female, came with a complaint of burns all of her body. So using the rule of 9, it was classified like uh, 9% in the right upper limb, 4.5% in the left upper limb, 9% in the anterior trunk, 4.5% in the abdomen, 9.5% in the back and paraspinal area, 4% in the right upper thigh, 4.5% in the face and neck. The total burn surface area for the patient was 45%. So coming to the anthropometric measurement for the patient was usual body weight was taken since we were not able to take the weight of the body, 81 kg. So with the 81 kg, patient indicated BMI as obese. So IBW percentage was above 120. So at adjustable body weight was taken. So procedure undergone by the patient was collagen application, BioBrain application, and bilateral upper limb stereotomy. So collagen application and BioBrain application is basically uh, application which is used for the second and third degree burn, and it usually peels off with 5 to 14 days, and yeah, and the bilateral upper limb serometry is actually to release the pressure of the dead skin. And may I move on to the next slide, please? Hello, may I move on to the next slide?
Yeah, just a second.
Okay, coming to the biochemical parameter of the patient, there is an decline in the hemoglobin level and decline on the second day on the albumin, sodium, potassium were elevated and declining. Creatinine was high, CRP was high. So that is basically because of the inflammation and infection of the body. So CRP usually increases in the acute phases when the liver responses for inflammation. The first 6 to 12 hours, there will be a elevation and usually it declines. Persistent elevation of the CRP indicates the inflammation and infection. So albumin on the second day was hypo due to the capillary leakage, due to the fluid shift, and potassium and sodium were due to the dilutions, and creatinine were elevated. In next slide, please. Okay, so coming to the diet history of the patient's intake was sedentary, and the patient preferred non-vegetarian, allergies were nil, and intake was moderate. So excessive junk consumption due to the personal preference, as evidenced by dietary record. And coming to the nutritional recommendation, we were using Quarry formula, and with the energy and protein is actually when the patient experience hypermetabolic state with increased basal metabolic rate, the energy requirement will be 2 to 3 times greater than the normal recommendation for the patient. Coming to the protein, due to high cortisols and catecholamines, muscle breakdowns will be leading to the weight loss and delay in the wound healing. So 20 to 25 to 30 calories for the body weight for Curie formula was as per Aspen guidelines. So to avoid the overfeeding, to avoid 25 calories were used with Curie formula, which gave 3,327 calories. Coming to protein, it was 1.2. The Aspen guidelines was 1.2 to 2 gram, and it was 2 to 6 gram of protein. Carb was 50 to 60 percentage. Since the patient is diabetic, 50 percentage of the total calories were given. 23 percentage of the total fat was given, and fiber recommendation were according to the diabetic, and fluid was 2.5 liter currently. And the first 48 hours, patient was on Parkland formula, where the fluid was calculated with 4 ml into body weight into total bone surface area. So first 8 hours, 50 percentage of the total fluid were given, and the next 16 hours, remaining 50% will be achieved. So usually flow fluids first 24 hours, crystallized fluids are used. That is basically our ringer lactate, normal salines, dextrose were used. That is basically a small molecule which can easily enter up into the cell, and it will increase the plasma volume also. So next 24 hours, after 24 hours, colloids were used. Colloids is actually our albumin, frozen plasma, etc. So it is a large molecule where it can stay longer. It will decrease our fluid loss also. And coming to the micronutrient recommendation, vitamin C, which helps in collagen synthesis and immunity, and vitamin A, it helps in epithelialization and immune function. Zinc for wound healing and protein metabolism. Selenium and copper, glutamine supplementation can be given for the burn patients, and it plays an important role in wound healing. So these were zinc and vitamin tablets and injections were given for the patients. Can I move to the next slide? Yeah, so the MNT goal for the patient in short term is to prevent the further metabolic stress and complication, and to achieve fluid and electrolyte balance based on session need. Initially, early enteral nutrition to maintain the gut integrity, maintain blood glucose control, provide essential micronutrients, monitor weight and nitrogen balance and healing process daily. For the long term, continuous wound healing and tissue regeneration with adequate energy and protein, prevent muscle loss and promote lean body mass restoration with high protein enhance immune function, and through the macronutrient and micronutrient optimization, improve functional recovery and strength through physical rehabilitation and nutritional support. So, yeah, ensure adequate hydration, electrolyte balance for the long term metabolic stability, educate patient on long term nutritional need to support skin grafting healing, and prevent infection and enhance the quality of life. May I move to the next slide?
Vinita, you're almost at your time, so try to wrap up as
Okay,
soon as.
okay. So on day 1, the patient was on NPO, and day 2, NG feed was initiated, and 39 percentage and 41 percentage of the calories and proteins were met through nasogastric feeds. And on day 3, again, the patient was NPO for the procedure. On day 4, it was restarted, and it was on the same since to avoid the refeeding syndrome. So the test was inadequate intake from the enteral nutrition related to the target goal to prevent the refeeding syndrome, as evidenced by less than 50% of the total target. So on the day 5th, the same feed was continued, and day 6, the energy calorie were increased to 60% and 50% of the calorie nutrient need. So the feed was increased to 75 ml per hour. And on day 7, the patient started taking sips of water and clear juices and clear liquids to encourage orally. And on day 8, there was a plan to remove the fatty tube and encourage orally. And it was same again, 60 percentage of the 50 percentage of nutrient recommendation. So can I move to the next slide? Okay, then day 9, the patient started taking orally. So it was achieved with the oral nutrition supplement. So for the 1 ml, 4 calories were initiated for the patient, and it was achieved 61 percentage and 50 percentage of nutrient need. And patient was taking orally, and it was not adequately, but it was usually achieved with oral nutrition supplement. So the patient was on diabetic high protein blend diet. On day 10th, the patient started taking limited quantity due to her pain over our mouth and lips and all. So the bowel movement was 1. And day 11, the patient was on NPO till 3 p.m. and restarted with the feeds, and patient was went for the Dharma. May I get the next slide? So this is the graphical representation of the hospital recall of the patient. So there is a decline and increase in the patient requirement. So that is actually because of the ICU protocol limitation, procedure limitations, and patient's acceptance due to her pain and discomfort in the abdomen also. So yeah, next slide. So this is the prescribed menu. It includes oral nutrition supplements, which is can be mixed in the food and through orally. And yeah, next slide. And extra virgin olive oil, broccoli, cabbage, cauliflower, all these macronutrient content is rich in vitamin B, zinc, selenium is all is added. So extra virgin olive oil, it is helpful in the anti-inflammatory properties. And the next slide. Yeah, next slide. Yeah, so coming to the conclusion, my Miss S, 60-year-old female, was bought with the complaints of flames all over her body, and she was no histories of loss of conscious, and she was a patient of diabetic and on medication. And the anthropometric measure reveals that it is obese, and biochemical parameters has elevated inflammatory responses. Clinical investigations was not done. So hospital recall during hospitalization improved gradually, and the patient counseled with diabetic high protein diet with the oral nutrition supplement. Patient was discharged and shifted to the another hospital for further nutritional management and medical management. Okay. Yeah, thank you.
Thank you, Vinita, for the elaborate presentation. Jury members, do you have any questions for her?
Benita, nice presentation. Congratulations.
Thank you, ma'am.
Just wanted to understand, how did you give attention to the fluid requirement and how
Yeah.
the fluid can be administered?
Yes, ma'am. Usually the Parkland formula is used on the first 48 hours. So the first day it was the input output was 11,048 ml and the output was 5,760 ml. The second day it was 6,123 ml and the output was 2,432 ml.
Huh.
Yeah, so a patient had intake and output, but the IV fluids, everything was initiated and RL was initiated soon after the admission.
Okay. Okay. And one more just comment that very thoughtful about the micronutrients which are normally not considered. We just understand the calorie protein requirement, but apart from fluid, micronutrients are crucial. So good thought about it. Thank you.
Thank you, ma'am. Thank you.
Any other jury members have any questions?
Yeah, Benita, I just want to know what are the discharge recommendations that you have given and the calorie protein recommendations post discharge.
Okay, so the nutritional recommendation was same as like 320 calories and 226 gram of protein as the prescribed menu was there. So with the support of hypercaloric oral nutrition supplement, diabetic high protein blend diet was given for the patient.
Okay.
Yeah.
And how did you manage controlling the sugars with these many calories? Though the requirements, nutritional
Yes.
requirements are very high, you'll have to again consider good glycemic control for the wound healing to happen.
Yes.
So, what extra recommendations did you give the patient to keep the sugars under control?
Okay. Through the blends, vegetables and the proteins were added, and the rice carb content was kept. And on the day one, patient had 206, and day third, there was elevation of 328 mg, the blood sugar level. On the day fourth, it was like 124. So patient had the spike on the daytime after her dressing time, and the patient had a control on evening times alone. So it was evaluated like that. And orally, she was not accepting very much food items and all. So because of her burns on her face also, no? Yeah, but there was a limitation in her food intake also, ma'am. But the quantity was like 200 ml second hourly was she was taking initially, and she could tolerate only 150 ml at a time.
Okay.
So it was administered like 100 ml each hour. So we to achieve more.
Okay. And
Yeah.
was there any insulin infusion?
Sorry, ma'am, I could hear you.
Was there any insulin infusion that was given?
Yes, ma'am. Yes, ma'am. Insurance infusions were going on.
Did you try adding any fiber supplement to control
Fiber
the
supplement
sugars?
in the feeds it is there. In the feeds we have added, and the oral nutrition supplement on the day 8th or 9th we had mixed in the feed also. Oral nutrition supplement, the fiber feed were added.
Okay. And see, this is a burns case. I would appreciate, this is a suggestion from my end, that you give a little, description of, how this much percentage of burns happened. I don't know whether, there was a network issue because of which I did not hear that part, or I don't know whether you've covered it.
No, the rule of 9 I have explained I mean
No,
which
how
part
did
and
she
all.
land up with so much of burns?
It is actually she was burning waste at her residence, and it caught her.
Burning what?
Burning waste at her residence.
Waste.
At her home,
Okay.
yeah. So
Waste. Okay, sorry,
yeah,
sorry, I
yeah,
was
yeah.
not able to hear. Sure, sure. Thank you so much.
Hi, Benita. This is Rajesh here. Could you able to hear me?
Yes, ma'am. Yes, ma'am.
Yeah. I have two questions from my end. One is Have you ever tried immune nutrition for your patients on burns patient? Any idea about it?
Immunonutrition?
Yeah.
Mm. Yeah, this is a very good, valid question, Rajeshwari.
Yeah,
Mhm.
because generally, its immune nutrition is essential for the burns patient.
Yes.
So I just wanted to know whether you have tried it at any point of time for this patient.
Like infusions were made, ma'am, but from my side, like as in, like in the feed, the nutrient, micronutrient recommendation, vitamin C rich for formulas were used.
Okay.
Like the
And
Pentastro 2.0 is used, it is rich in micronutrient need also. So like as such immunonutrient, it is not like omega-3 or glutamine, arginine and all. It was not used.
Okay, but thing is actually you can use in future. Probably you can try it out because that will give a good effect for the results for the burns patient. And
Yes,
one
ma'am.
more thing is I haven't seen any tools that is being used for your assessment. Any specific tools you used it?
Yeah, my SGA score. Sorry, I couldn't. Like,
Okay. So that I just wanted to know whether you have used any specific tool or something like that.
yeah.
Okay, thank you. Thank you.
Thank you.
Yeah. Benita, I have another question for you.
Yes,
Um,
ma'am.
have you made a slide for pest statement? Have you defined the pest statement?
No, the on the day recalls, I have mentioned test statement in the remarks column.
Okay.
Yeah.
So, what is the nutritional diagnosis that you have given then?
So actually inadequate oral intake related to the clinical condition and the limitation as evidenced by like dietary recall. So on the day, every day, like in a restricted oral intake where due to the clinical condition as evidenced by NPO status, so it was referred in the each day.
Yeah. And how often were you reassessing her?
Every day, ma'am, like a 24 recall, I mean, every hospital recall was taken. I mean, until the patient was on admitted, like day 11, I had the
Mm.
patient, and day 11, she was shifted to some other hospital for further management due to the financial crisis and all.
Okay.
So, till
And
that
one more
day,
point is, see, whenever she's taken up for the dressing and all that, you would miss
yeah.
out on her feeding. So, would you make an effort to catch up those feeds at night?
No, ma'am, night feeds usually were not practiced
Additional
actually
feed you would have tried it
because
out actually.
Yeah.
the patient was on little bit of abdominal discomfort also. It was not
Mm.
distension as such, but she was not able to take that much of feed when it comes to oral. So
Okay.
yeah, she was not, first of all, she was not accepting orally the thing.
Mm.
And then the night feeds were not practiced also.
How frequently was she taken up for collagen dressing?
Uh, on the day first and third, she was on completely on NPO for
Mm-hmm.
24 hours.
Mm.
And day 11, she was taken early morning, she was taken for 10 hours, she was taking, and dressing time was taken on NPO, ma'am. It was not as such NPO for these many hours, but they
Yeah.
have to keep for the dressing, and then after 1 or 2 hours, they will start feeding, you know. So
Okay.
after dressing, she'll be like completely down. Yeah.
Okay. Okay. All right. Thank you.
Thank you, ma'am.
Wonderful, Benita. Very good answering all those questions by jury members.
Thank you, ma'am.
Yep. And we will move on to our next presentation. It's Miss Saloni Pradhan. Saloni, are you ready?
Yes, ma'am.
Okay. Sari, please go ahead and share your presentation. And you have 12 minutes. Please stick to your time so others can have enough time to present.
Okay, ma'am.
Thanks.
Good afternoon, everyone present over here. I, Saloni Pradhan from IMS and Some Hospital, Bhubaneswar. I will be presenting on geriatric nutrition in medical nutrition therapy. Based on my case study focusing on screening key result clinical implementations. So we cannot add years to life, but through nutrition we can add life to years. Let me begin with why this topic is so crucial. First of all, before going through the topic, we have to know what is geriatric nutrition. Geriatric nutrition is a specialized field of nutrition focuses on the dietary needs of older adults, aiming to maintaining their health, manage chronic illness, and improve their quality of life as they age. It belongs to different age group divisions. Uh, for example, 65 to 74 were young old, and 75 to 84 were middle old, 85 plus were older olds. Then I will go to the next slide. This was a descriptive study on elderly patients admitted in wards. Nutritionally status was assessed with the M&A tools. Data was statistically analyzed using chi-square test. Then I will move to the next slide. This is my aim and objectives of the study. The aim was to evaluate nutritional status using the MNA tool, which helps to identify risk factor and suggest evidence-based interventions. Next slides. This is a geriatric physiology. Did you know that after 65, the efficiency of our organs decreases gradually? That's why elderly patients responded differently to medications and treatment. Next slide, please. Key health issues in geriatric. What are the most common health struggles you see in elderly patients? That is malnutrition, dementia, and fall. Even a small falls can cause major fractures due to weak bone. That's why elderly care requires a comprehensive care. Next slide. Pathophysiology changes. Aging doesn't just affect the body impact, however, energy is used, how we think, and even how we heal. Then I'll go to next slide. Nutrition in elderly. The good news is nutrition plays a powerful role in health and aging. Deficiency, there are protein, vitamin D, vitamin B12, calcium, and fiber deficiency. Protein, there is 1 to 2 gram kg per day for muscle maintaining, and we can give like egg, milk, pulse. Then fiber, we have to give 25 to 30 gram per day. For example, whole grains, fruits, and vegetables. Hydration should be maintained at least 6 to 8 glasses per day. Next slide. And this is my questionnaire. Based on these questionnaires, I have prepared my graph. So let me show why. Let me show you the findings. Next slide. This is the results. Gender demographics. In my study, populations 56.8% were male and 43.1% were female, indicating a slightly higher representations of males. Then I will go to the next slide. Food intake and weight changes. Food intake declines was notable in several patients regarding weight changes. 51% had no weight loss, but 21% lost more than 3 kg in 3 months, a clear for malnutrition risk. Then I will go ahead to next slide. Mobility plays a huge role. 59% were active, but about 11% were bedridden. Also, physiological stresses affect 42% of patients. linking directly to reduced food intake. Then going to the next slide, neurophysiological conditions. Mentally health matters. 22% had mild dementia and 2% have severe conditions, both impacting food planning and intake. 76% showed no major disturbances, which is positive. Then I will go to the next slide. BMI and nutritional status. BMI distribution showed 50% were overweight, but MNA revealed 48.5% at risk of malnutrition and 25.7% already malnourished. This contrast shows that BMI alone is misleading in geriatrics. Then I will go to the next slide. Living status and drug intake. Living status shows the 60% live independently, while 54% patients were on more than 3 drugs daily. Polypharmacy is an important factor as it affects nutrient absorptions and appetite. Then next slide. Bed sores and meals intake per day. Only 10% had bed sores, but diet frequency showed concern. 21% consumed only 2 meals per day, which increases malnutrition risk. Then I will go ahead to the next slide, which is protein and beverages intake. Here in this graph, I will show that protein deficiency was clear, 21% reported no protein intake. Hydration was also poor, 39% consume less than 300 ml fluids intake per day. Then I will go to the next slide. Mode of feeding. Positively, 82.85% could eat independently, but 17% of patients required assistance. These patients are nutritionally most vulnerable. Then go to the next slide. Anthropometric method. Mid-arm circumference and calf circumference. Mid-arm circumference showed 21% were below 21 centimeter and calf circumference showed 59% were below 31 cm, both indicating muscle wasting and malnutrition risk. Then I will go to the next slide, which is hypothesis. I have taken a chi-square test at 1% level of significance. Chi-square test result is p equals to 0.049, indicating no strong associations between number of meals and nutrition status. This tells us meal quality matters more than just numbers. Then I will go to the next slide. Discussions. Nearly 75% were either malnourished or at risk. Reduced intake, stress, and mobility were key contributors. This highlights the importance of routine screening. Then this is the conclusion. The MNA tool proved effective in screening. Routine nutrition assessment must be included in geriatric care. Intervention should focus on protein-rich micronutrients, dense diets, hydrations, and regular monitoring. So, nutrition is not optional in geriatrics, it is a medication. Thank you.
Thank you so much, Salone, for your presentation. It's open for the jury members for questions now.
Hi, Saloni. This is Rajeshwari here.
Hi, ma'am.
Hi. I just have one question. Few things I just wanted to make it clear. You have done a medical nutrition therapy for geriatric population in the hospital, the hospitalized patient, right?
Yes, ma'am.
Okay. But don't you think that medical nutrition therapy will differ from one specialty to the other?
Sorry, ma'am, I'm not getting.
Like medical nutrition therapy will differ from one specialty to the other, from one diagnosis, from a disease specific factors. If you see, it'll differ from one disease to the other disease. The medical nutrition therapy will be varying it, right?
Yes, ma'am.
It will not be common for all, right?
Yeah, ma'am.
Okay, so first thing that I just want to have it, and second thing is what intervention you have done it for a geriatric population in a hospitalized patient. Anything specific you people have done it, because you have noted on the intake, protein intake, specific monitoring you have done it. So any specific interventions you have done for the elderly population in the hospital?
Ma'am, there is no specific diet.
Okay.
Okay, ma'am.
Yeah, Saloni, thank you so much for the presentation. I just have one question. See, you are actually showing us the table and the graphical representation of the nutritional inadequacy that was there in the geriatric population. So, what is the extra effort that you have put in to meet up the nutritional needs, especially protein, when you were doing the intervention?
Fat soluble vitamins, minerals, fibers.
Protein, I'm asking about protein, Saloni.
Ma'am, soya protein, paneer, milk product.
Okay. How much? How much were you giving?
Ma'am, 1 gram per kg weight.
Okay. And your subjects, were they non-vegetarian also?
Yes, ma'am.
And in non-vegetarians, you did not intervene giving soya and all that. Then
No, ma'am, I have given.
you have given.
यस मैम मतलब वेजिटेरियंस जो लोग हैं वो लोग को प्लांट बेस्ड प्रोटीन हम लोग देते हैं एंड जो
हाँ
लोग नॉन वेजिटेरियंस हैं उन लोग को हम लोग एनिमल प्रोडक्ट प्रोटीन्स.
हाँ हाँ, वही मैं पूछ रही थी आपसे. अगर कोई नॉन वेजिटेरियन है तो उनको भी ये सोया प्रोटीन एंड पनीर दिया था,
हाँ
या
मैम
सिर्फ
वो लोग
नॉन
भी.
वेजिटेरियन इन
नहीं मैम
वेजिटेरियंस को दिया था?
वो लोग भी खा सकते हैं मतलब दिए थे हम लोग.
अच्छा अच्छा अच्छा, ठीक है ठीक है.
ओके
ठीक है, अंडरस्टूड. या, थैंक यू सो मच.
थैंक यू मैम.
Saloni, congratulations for selecting this topic. It is actually not very well spoken about, much spoken about actually. So thank you for selecting this topic. I would be more interested actually about the intervention, whatever the theory part is there, actual intervention, like what challenges you might have faced. For example, suppose we talk about proteins, but geriatric population will invariably have some compromised renal function, some compromised cardiac function where fluid is a challenge. So, did you face any of the challenges like that, and how did you tackle them?
मैम जो जेरेटिक पेशेंट्स थे मतलब जेरेटिक एज ग्रुप्स थे उन लोग का तो कार्डियक एंड रेनल डाइट भी उन लोग का चल रहा था बट जिनका रेस्ट्रिक्शंस है उनको फ्लूइड रेस्ट्रिक्शंस एंड प्रोटीन रेस्ट्रिक्शन 0.8 ग्राम प्रोटीन पर बॉडी वेट हम लोग देते थे उनको एंड एज पर डायग्नोसिस का उनका कंडीशन देख के हम लोग उनको डाइट प्रोवाइड करते थे.
Any other challenge? इम्प्लीमेंटेशन करने के वक्त कोई अलग चैलेंज आया कि उनका अडियरेंस, कंप्लायंस, रेजिस्टेंस?
मैम उनका कुछ ऐसे कंप्लेंट्स तो नहीं आता था बट वो लोग थोड़ा थोड़ा मतलब लॉस ऑफ एपिटाइट था कुछ पेशेंट्स का एंड उन लोग को डाइट दे के हम लोग उनका इम्प्रूवमेंट भी करवाए थे डाइट दे के न्यूट्रिशंस.
Thank you, Saloni.
Thank you, ma'am.
Okay. Are we good with the questions? Great. Saloni, thank you so much for your
Thank you,
presentation.
ma'am.
Very well thought of topic. We will move to Raju. Do you want to do the quiz now, or do you want to wait for one more presentation?
Yes, ma'am, we can do it right now.
Okay, yeah. So Raju is going to do the quiz. Like I mentioned in the beginning, we are going to have a very quick quiz for all the participants, and you will have an opportunity to get a certificate today. So Raju, please go ahead and get
Yes,
started.
ma'am.
Before you begin, Raju, our next presentation is by Sushri Mahakut. Sushri, please be ready for your presentation. Once we are done with the quiz, we will go ahead with your presentation. Thanks.
Yes,
Dear,
ma'am.
dear all, I have shared you this quiz link. You can click on that, and I will share you the pin so that you will have to enter that pin. I have shared you the pin also 697391. You will have to enter this pin so that you will be entering. And while you enter, you will have to write your name properly. Please write your name properly, or else it will pick up any random name. It will not be good. The name that you want to. So people are still joining. We'll wait for 1 2 minutes. Then everyone will join. Dear all, please enter your valid name. So we'll be starting sharp at 4:42. Those who want to join, please join as soon as possible. So I think we should start right now.
I want to join, but I could not. Please guide.
The quiz contest has been started, so we can't do anything right now. Um,
Please করে যাই।
you can scroll the scale over here. Congratulations to all. So these are the three winners who will be receiving the certificate of Nutri Health Foundation, and to all the others also, we would like to congratulate for your efforts in this regard. Thank you so much.
Wonderful. Thank you, Raju, for conducting
Yeah.
it. And thank you so much for participating. And congratulations to all the participants and the winners. Okay, so let's move along with our presentations. Shushri, are you ready? Unmute yourself, please. Sushri, you're muted.
Ma'am, am I audible?
Yeah, you're echoing now. Are you logged in both the
Ma'am, am I
devices?
audible now?
Yeah, better. Thank you. Sai, please go ahead and share her presentation, please. And Shushri, you have 12 minutes. Please stick to your time, and then we will take questions from the jury members when you're done.
Yes, ma'am.
All right, thanks.
Okay. Very warm afternoon to all the panel members and my fellow participants. Myself, Shushri Makar, and today I will be presenting on the topic nutritional assessment of malnourished patient in ward settings. May I have the next slide, please? Okay. So first of all, before diving into my case study, I would like to explain that what exactly is malnutrition. So mal and nutrition, two terms. Mal means something which does not function properly, and nutrition means a substance which is required by our body for the proper functioning of our body. So combined, they form one single word, that is malnutrition. Means when there is the abnormal functionality of a substance in our body, that is known as malnutrition. So malnutrition has three categories, that is undernutrition, overnutrition, and the MRM. So undernutrition, a person suffering for undernutrition goes to stunting, wasting, or underweight. A person who has overnutrition is undergoes obesity or diet-related non-communicable disease such as diabetes, heart attack, or cancer, especially people who are suffering from breast cancer. Now, when we go to MRM we have two categories, that is the MRM deficiency and the MRM excess. For the MRM deficiency, a person may undergo conditions such as scurvy or maybe anemia. For excess, there is hypothyroidism conditions or maybe acromegaly conditions. Now, may I proceed to the next slide, please? Okay, now coming to hospital malnutrition, as we know that nutrition is very much important for the healing of a patient, and especially diet plays a very important role in the healing of a patient. It reduces the hospital stay of the patient, helps in the healing of the patient. So, what is hospital malnutrition? Now, hospital malnutrition generally refers to a condition that a patient develops while his or her stay in condition. When a patient is admitted to the hospital, the patient may may already be suffering from malnutrition or suffers from malnutrition during his or her hospital stay. Now, there may be various factors why a person suffers from malnutrition. First condition may be the underlying illness, like if a person is suffering from conditions such as diabetes or maybe any kind of terminal illness such as cancer, etc. So we can see that there may be a reduction or increase in weight of the patient. There may be decrease in appetite, or there may be difficulty in eating of the patient. And next condition is the reduced food intake. Usually, patients who are admitted in the hospital undergo a condition of reduced food intake that may be due to different kind of medications or maybe procedure or pain. And even certain conditions such as the inflammatory bowel syndrome and certain medications also affect the body's ability to absorb nutrients from the food. And also there may be a combination of factors, like if a person is suffering from disease such as cholelithiasis, etc., then these factors may in combination affect the patient. And usually 20 to 50% of patients that are admitted in a hospital suffer from hospital malnutrition. Now, may I go to the next slide, please? Okay. So these are the consequences of the hospital malnutrition. As I said earlier, there may be like longer hospital stays of the patient. There may be increase in a rate of mortality. There may be worsened health outcomes, like the condition of the patient may deteriorate. And also there may be like higher healthcare cost when a person is admitted for a very long time in the hospital. Now, what is the importance of recognition and intervention? Now, this is the point where the role of a dietitian comes into play. It's like if we identify the malnutrition condition of a patient in an early stage, then we can give a proper nutritional support to the patient. We can address the underlying condition, and thus we can improve the health condition of the patient and also decrease the hospital stay of the patient. Next slide, please. Okay, so now the role of nutrient in hospital settings. As I've said earlier, that nutrients play a very major role. Both macro and micronutrients have a very important role. Like when we talk about the macronutrients, that are the carbohydrate, fat, protein. They like carbohydrate and fat. They act as the major source of energy. Carbohydrate also prevent the protein from sparing, so that the protein can perform its main function, that is the growth and development of the cells. When we go to the micronutrients, that is the vitamins and minerals, there are certain vitamins as well as minerals that help in the cellular development of the patient. Like when we talk about magnesium or selenium, selenium is acting as an antioxidant. Also, magnesium helps in various metabolic functions that is occurring in our body. Vitamins also, like when we talk about vitamin C and D, they are very much beneficial for patients who are suffering from cancer, as they help in the immunity system. And when we talk about roughage and water, although not mentioned very often, but roughage and water play a very major role in the condition of a patient. Like roughage, if we say, then they help in the proper digestion of a patient, and water also helps in digestion and proper absorption of nutrients in the body of an individual. Next slide, please. Now, these are the types of therapeutic diet that is provided to a patient according to their medical condition, that are liquid diet, soft diet, and normal diet. Liquid diet are of two types: clear liquid diet and full fluid diet. And then comes the soft diet. Soft diet is kind of a bland diet, and normal diet is the like normal food that the patient can eat according to their disease condition. Next slide, please. Now, these are the aims and objectives which I took for my study. The aim is to assess the nutritional status of malnourished patient in hospitalized setting and ward. And as per the objective, I use the food recall method to monitor the food intake of the hospitalized patient in ward. And I used the SGA, that is the subjective global assessment, to assess the baseline nutritional status. My objective was also to determine the dietary intake of the hospitalized individual, and if the prescribed diet is influencing their health condition. And also I did this research to identify the barriers of inadequate intake during the hospitalization. And last but not the least, what was the role of the nutritionist in the food intake of the patient. Next slide, please. Okay, coming these are the results. Next slide.
So from the SGS score distribution, that is the subjective global assessment, I found out that about 55.36% of the patient were moderately malnourished, whereas 8.93% were severely malnourished. And out of these malnourished patients, next slide please. Out of these malnourished patients, I found that majority of the patients were female. That was 58.82% of my patients were female. Next slide, please. And then I came to the age demographics of the malnourished patient. In the age demographic, I got to know that majority of the patients who were malnourished were either old adult or middle-aged adults. Next slide, please. Okay. So when I did a disease versus malnutrition graph, I found out that majority of the patients who were malnourished were suffering from any kind of terminal illness, such as cancer or any kind of cardiac problem, or maybe CKD patients. That was, as you can see in the graph, it is 23.53% of the patients had terminal illness. Next slide, please. Next, I also got to find that 73.21% of the patients who were malnourished had a single or multiple comorbidities before they were being admitted to the hospital. Next slide, please. And when I did a malnutrition versus habitat graph demographics, I got to know that majority of the patients who were malnourished belong to the urban settings, which also gave me a hint that maybe the lifestyle can be a huge barrier towards the malnourishment development in the patients. Next slide, please. So this was the required protein versus the given protein, that when the patients were admitted in the hospital, this was the first required versus given protein that was being given to the patients. Next slide, please. And this was the required calorie versus the given calorie to the patients, like when they were first admitted to the hospital. This was of the day one record. Next slide, please. Now, the patients were being the patients were being counseled daily. From day 0 to day 7, they were counseled daily by the dietitian. And as you can see that there is an average increase in the calorie intake of the patient from day 0 to day 7. Next slide, please. Likewise, there is also an increase in the average protein intake of the patients after they were being counseled daily by the dietitian. Next slide, please. Also, I found out the poor intake analysis chart, and I got to know that majority of the patients had a poor intake due to condition that is nausea and vomiting, which may be due to their disease conditions. Next slide, please. And the last but not the least, I found out their intake in the date of admission versus their date of discharge. And as you can see that in the date of admission, 52.32% of the patients had proper intake, whereas in the date of discharge, 71.7%, there was a significant increase in the intake of the patient in the date of discharge. So this was my presentation on the malnourishment assessment of the patients in the ward. Thank you.
Very good presentation. Very good presentation, Sushri. And it's open for jury members for any questions.
Sushri, good presentation.
Thank you,
Why
ma'am.
is it echoing?
Why there is echo? Okay.
Go ahead. Yeah, you just keep yourself muted, Sushri. I think it's on your end. There are two devices logged in, I believe. Go ahead, Ms. Vaidey.
Yeah, just wanted to comment, no questions from my end, but good presentation and good topic. And you need to, maybe if this is your interest, then you can take up the same topic for the malnutrition during the ICU stay. Like, to be very specific, wards are there, but ICU can be more specific. So thank you.
Yeah, I agree.
Thank you, ma'am.
Thank you, ma'am.
Yeah, so Shri, the topic that you have taken is excellent, but I would, suggest that you should take more parameters to compare. Like if you're meeting up the nutritional requirements, how the outcomes are getting better. So other than the date of admission to the date of discharge, other than the length of stay, is there anything else that you had compared against meeting up the nutritional needs? Am I
Ma'am,
audible?
I also noticed that the diet the patients were being provided, the length of stay of the patients when we provided them with the high calorie, high protein diet to the malnourished patient, the length of their stay has significantly decreased in the hospital.
Yeah, that's what I asked. Other than length of stay, is there anything else that you have, assessed, measured?
Ma'am, I took out a hypothesis upon the malnourished patient where I got to know that gender also plays a very important role among the patients those who are being malnourished. Like major of the patients who were who are malnourished were female, as you saw in my presentation, and gender plays a very specific role among the people who are being malnourished. This may be due to their lifestyle or maybe due to our customs or culture. So this was one thing that I got to know. Also, there was one age factor that I got to know.
Yeah.
And also, I assessed one thing that lifestyle also plays a very important role. One more thing which I got to find out that majority of the patients who were malnourished had many hormonal imbalance in them. Like I asked them some question, many of the patients had symptoms such as frequent urination or feeling too hot or too cold compared to others. Also, I couldn't put it in the slide because hormonal test can hormonal imbalance can be we can see hormonal imbalance through medical test. We cannot just question and put them, but this is one thing that I assessed while I was doing this study.
Yeah, and how did you measure the degree of malnutrition in these patients?
Ma'am, I used a subjective global assessment tool to assess the degree of malnutrition in the patients.
And did you categorize them as underweight, overweight, and malnourished? Are you there, Sushri? Am I audible?
I think she has
Ma'am,
echo. It's just being.
basically, major of the patients that I saw were undernourished. I didn't get any patient there were very few patients who were overnourished, and majority of the patients that I studied were undernourished. They were underweight.
Okay, Sushri, thank you.
Hi, Shushri. This is Rajeshwari here.
Good afternoon, ma'am.
Yeah, good evening, ma'am. Actually, have you ever tried comparing with different tools for the assessment instead of using one tool, subjective global assessment alone? Have you ever tried any other tools for nutritional assessment?
Ma'am, there is one more tool that is MNA, mini nutritional assessment, that is being used for the nutritional assessment of the patient.
So those data is also you presented here. Shushri?
Yes, ma'am.
Okay. Yeah, mute one of your devices and then answer because there's a lot of gap between.
So you have presented those data also here. Those assessment tool data is also here.
Ma'am, can you please repeat?
No, I'm asking whether you had any other type of tools also you used for nutritional assessment. You have used the SGA and you said, yeah, we used the other tool also. So I wanted to know what tool you used and whether you have represented the data in this presentation. I just want.
Ma'am, different one more tool is being used, that is mini nutritional assessment is being used. But for
Okay.
this study, I took only the SGS score into consideration. But apart from that, in general settings, we also use the mini nutritional assessment.
Okay, fine.
And where there are different questions like have the patient like food intake declined over the past 3 months, and was there any kind of weight loss in the last 3 months, what is their protein serving, like what is the protein serving, and what is the mode of feeding, like do they require any helper for food consumption. Such questions are there included in the M&A, and in general settings patients are being questioned in this way. But for my study, I was only focused to the subjective global assessment.
Okay. Okay. Fine. Thank you.
All right. Wonderful presentation, Sushri. Thank you, jury members, for those thought-provoking questions. So we will move ahead. And the next presentation,
Thank you, ma'am.
presenter, yeah, sure. The next presenter is, okay, is Pooja Maheshwari. Pooja, are you ready?
Yeah, yes, I'm ready.
All right, great. So, Sai, please go ahead and share her presentation. And Pooja, you have 12 minutes to do your presentation, and then you'll have a couple of minutes for taking questions from the jury members. All the best.
Thank you, ma'am.
Sure.
Hi, good evening. I'm Pooja Maheshwari from Medanta Hospital, Indore. And my case is PNC with vulvar dysfunction. PNC is polynucleus cranial, is extremely rare variant of GBS. Is usually characterized by ocular and pharyngeal weakness without obvious numbness or weakness. And bulbar, also neurological condition, impair muscles in the throat and face. Muscle weakness. Leading symptoms for bulbar dysfunction is difficulty of speaking, dysphagia, and voice changes, respiratory infection, respiratory distress. Also, next slide, please. My case, my patient present complaint in admission status complained of double vision,
बाथरूम किसका भी नहीं है
swallowing in last 1 week, abnormal speech in last 15 days. Provisional diagnosis and admission status diplopia is double vision, admitted to further management. Final diagnosis is PNC and bulbar dysfunction with Miller-Fisher syndrome and myasthenia gravis, just like a GBS. Next slide, please. PNC and bulbar dysfunction introduction also introduced, and Miller-Fisher syndrome is a rare disorder that causes your immune system to attack nerve often in your face. It can cause issue with eye and facial movement, coordination and balance. A chronic neuromuscular disease is gravis, myasthenia gravis, that cause weakness in the vulnerary muscles. Vulnerary muscles include muscles that connect to a person's bone muscles in the face and throat. Next slide, please. GBS, GBS is the body immune system attack, part of the peripheral nerve system. That syndrome can affect the nerve that control muscle movement. This can result muscle weakness, loss of sensation in the legs, arms, face, eyes, and problem swallowing and breathing. Next slide, please. GBS epidemiology is the reported incidence rates of GBS in 1 to 2% lakh population. Subtypes of GBS have different incidence in different parts of the world. In Europe and North America is dominant, contributing to 90% of cases is AIDP, acute inflammatory demyelinating polyradiculoneuropathy. And in China and Japan, being the most common subtype is Aman, and in India series, the incidence of AIDP and Aman are virtually equal, although more common younger patients is Aman. Aman is acute motor axonal neuropathy. It's a subtype of a GBS characterized by the immune system attacking and damaging the motor nervous axons. Next slide, please. GBS damage myelin, the human neurons, tingling and weakness, muscles weakness, loss of reflexes, difficulty with eye or facial movement, and severe cases. Next slide. My patient profile is, he is a 16 years old, a pediatric patient, male, Hindu, and food habits is vegetarian. Actually, he is XOG patient, is a Jain community. Next slide, please. Clinical findings, febrile pulse is normal, CBC is normal. All electrolyte balance is normal, CFS normal, MRI brain drive sequence diode for lower cranial nerves. Next slide, please. This is a biochemical parameters at the time of admission and at the time of discharge. At the time of admission is HB is 15.5 and at the time of discharge is 12.0. Patient was obesity, but he's admitted admission time his weight is 84 kg, but on discharge time his weight is 78 kgs. Next slide, please. This is a pediatric nutritional assessment. We use TAM is 80 Z scores and all nutrition assessment part is a nutritional condition myasthenia, possibly to recently decrease recently decrease in nutritional intake. Next slide, please. Patient BMI is used as screening tool, identify possible weight problems. Calculator is BMI is high, BMI is 30, and his Z score is 1.96. Z score is the standard deviation above or below the mean. A positive Z score indicate the data point is above the mean, and negative is indicate the data point is below the mean, and the Z score is 0 means the data point is exactly at the mean. But my patient is obesity, Z score is 1.96 and percentile is 97.5. Age-based pediatric growth reference chart is there. Next slide, please. Patient home recall, patient excessive junk food consumption due to personal preference as evidence of dietary recall. Generally, patient have chips and restaurant foods, and nutritional is 1500 calorie, protein is 37, is patient home recall, and carbs 175. They will not meet. His diet intake was insufficient to meet this complete nutritional requirement, lead to various health issues, including weakness, immunity, and increased risk of chronic diseases. Next slide, please. My patient stayed in hospital 16 days. Last 7 day patient was low food intake, difficulty of swelling, difficulty of speaking and walking also. Developed respiration issues with low oxygen saturation. And admission state patient was saturation issues and difficulty of swelling and speaking. Then first day patient was NBM. Second day start RT feeding, second 100 ml second hourly. After 6 afternoon gives 6 feed. Third day planned intubation for ventilation support. Next slide, please. Patient usually intake outdoor food, wafers, chips. That's why patient diet advice, actually recommendations for RDA is 2800 to 32 is normal recommendation. My patient is overweight. That's why actual recommendation energy is 2000. Protein is normal recommendation is 52 gram normal recommendation, but patient was GBS condition that advise high protein diet 1.3 gram per day. Ideal body weight 83.2. Carbohydrate is 864 gram, 40%. Fat 32 gram, 20%, and calcium is 1300 milligram. Next slide, please. Patient came in hospital complaining with swelling difficulty. Main treatment for GBS. Intravenous immunoglobulin is a common first-line treatment. Is IVIG, delivery healthy antibodies and plasma therapy, hospitalization in ICU, nutritional support is main support, physical therapy and pain management, monitoring respiratory functions also. Next slide, please. Medical nutrition therapy of GBS prevent malnutrition, support immune function and healing, maintain muscle mass and energy levels, adapt of swelling of gastrointestinal issues. Nasogastric and gastric tube feeding should be instituted early and slowly. High energy 40 to 45 kilocalories and protein is 2.5 gram per kg has been recommended so as to reduce muscle wasting and assess respiratory weaning. Continuous enteral feeding seems to be better tolerated than bolus feeding in these patients. Surveillance for infection with weekly or more frequent sputum and urine cultures and blood count may be useful, but the use of these tests should be guided by clinical circumstances. Next slide, please. Key consideration. Firstly, key consideration, patient nutritional status, adequate protein to support muscle strength, balance energy intake of overall health, hydration and electrolyte management, texture modification, nutrition dense food and supplement support, potentially supplement vitamin D, omega-3 and fatty acids, and creatinine for strength, muscle mass, small frequent meals, monitor nutrition status and adjust plan accordingly. and consultant discussion. Next slide, please. My patient start first day is NBM and second day start rise to be feeding 100 ml per hourly. He per second hourly feeding tolerance, no signs of aspiration when observed. Progression based on good tolerance that RT volume was increased gradually 150 to 200 ml every 2 hours. My patient is 10 days is RT feed gradually increased. First day is 100. Third day is patient RT feed start is 150 ml second hourly with supplement support. We support Pentasure 2.0 and Pentasure fiber with creatinine supplement 3 gram per day, 1.5 gram BD. Next slide, please. This is a RT feed feeding formulation जो हम patient with 2.0 QID 150 ml second hourly. Next slide. Exchange list of rice to feeding cereals is one exchange is 30 gram. This is a proper exchange is 1667 kilocalorie with supplementations and kitchen feed also. Next slide, please. This is a patient rice to feeding is 200 ml second hourly with Pentasure 2.0 and fiber and also added creatinine. 150 ml warm water with 5 scoop Pentasure 2.0 with we use 5 feeds with commercial and 4 feeds in kitchen feeds. Next slide, please. With feeding schedules, patient have constipated, then use Pentasure fiber TDS, 1 scoop per feed, 100 ml curd feed or 100 ml whey water feed. Next slide, please. Continues to monitor bowel movements and signs of feeding intolerant. Discuss with medical team that plan to decanalization to tracheostomy and begin feeding trials. Should schedule a swallowing assessment to evaluate the patient readiness of oral intake. 12-day oral with RT-FIT start, oral 150 ml fourth hourly and RT-FIT is 200 ml third hourly and patient shift to step down. Patient conscious alert discuss with doctors and intensivist planned deanalyzation and day 13 deanalyzation midnight NBM. 14-day deanalyzation done and start RT-FIT 150 ml second hourly and after 2 hours start oral with liquids. Oral swallowing test is successfully done. And then with liquid successfully done and then start soft diet oral trial or a swelling test was performed using oral trial with soft and is successfully done. Then intensivists and doctors will discuss and try to remove RT and patient shift to oral diet with supplement support. As continue monitoring oral intake and tolerance test, soft diet and patient recovery. Next slide, please. Gradually advance to a normal diet as tolerated. Consider RT tube removal and monitor for any signs of aspiration or feeding related complication. Follow up with dietitian and speech language pathology as needed. RT tube removed if an oral intake remains adequate. Continue oral feeding with the soft diet or normal diet progressive as tolerated. A personalized diet charts were provided to guide nutritional intake post discharge. Nutritional counseling was given to the patient, caregiver regarding diet progression, hydration, and balance intake. Patient attenders and patient caregivers give advice with supplement support and fiber support with oral diet and normal diet intake is calorie introduced to 1800 calorie per day and protein is 1.3 to 1.5 gram per day per kg body weight. And patient follow up come to 15 days and patient was very is okay and now after 1 month patient come in hospital for follow up 1 month and patient now is okay. Patient weight loss is 5 kg in hospital state but now he is normal weight 85 kg weight is now and he is performed an exercise gradually a normal exercise just like a walking easily without any support. Next slide. This is an interpretation for day 1 to day last for 17th day patient in hospital state. Patient was intubated and start RT feed and then last is patient oral normal diet. Then patient have energy, calories, protein. This perform graph. Next slide, please. And short-term and nutrition goals and long-term nutrition goals for GBS patient not and also a discharge patient achieve at least 75 to 100% of estimated energy and protein needs through oral and enteral nutrition within 7 days. Improve meal tolerance and intake by adjusting food consistency. Example, soft, pureed, enteral feeding and liquid diet. Manage symptoms such as early satiety, fatigue during meals or gastrointestinal discomfort. Maintain adequate hydration through oral or enteral foods as appropriate. Begin nutrition education tailored to the patient ability and cognitive status. Focus on nutrition dense food. And long-term nutrition goals after discharge support neuromuscular recovery through optimal intake of protein, antioxidant, essential micronutrient just like a vitamin B, vitamin D, zinc, omega fatty acids. Promote independence with feeding as motor function, improve self-feeding, preparing meals. Transition from enteral to oral intake as swallowing function returns. Prevent complications such as pressure ulcers, infection, or malnutrition related rehospitalization. Implement a long-term balanced nutrition plan to maintain muscle mass, energy, and functional capacity. And patient follow-up for every month and rechange and check patient dietary intake and physical activity. Next slide. This is a diet chart. We give diet chart after doctor discussion. Is diabetic because of low sugar diet chart is 2000 kilocalorie and 87 gram protein and 250 gram carbohydrate. Is low in sugar, used in sugar free or stevia with high protein supplementations and millets, whole wheat porridge, lunch, mid morning, all meal. All our standard meals used millets and high protein substitutes. Thank you. Patient come in follow up after 15 days, continue soft diet and advance gradually to regular diet as tolerated. Patient is normal without support walking and without support speaking also. Now is going to school normally and started studying without support. Thank you.
You're welcome. That was good presentation, Pooja. Can you go back to the slide where you showed us the tool that you have used? Which slide number was it? Do you remember?
Yeah, it's the second last slide. It's the last slide, I think. It's the last slide.
I want to see the tool that you have used. Have you talked about that? And I know you mentioned it. I just wanted to go back to that slide, but that's okay. All right, go ahead, jury members, with your questions for Pooja. And then we have Gayatri. Gayatri, please be ready.
Pooja, good efforts, good presentation.
Thank you.
One thing which I like that I kept the follow-up even post-discharge also. That was nice one. Two things. One suggestion is never mention any product details when you're presenting the case study. So you have to mention the medical nutrition or scientific formula used. So please don't mention the names. Secondly, when you during the transition of the diet, you started with the liquids and then you said there was no aspiration. But we have. Are you aware about the dysphagia grading? Which is used where if at all any muscle impairment, especially while swallowing, then we have to involve the speech therapist to make sure and understand what grade of dysphagia the patient is in. So then accordingly we can understand whether patient should be on semi-solid diet, thick liquid, liquid, thin liquid. That is something which needs to be taken care of.
Firstly, speech therapy is included in this therapy started for swallowing test and others. Firstly, we use clear liquids. Our patient was tolerated good. Then 2 hours observation and discuss with speech therapist. He was clean chit with patient was okay. Then we start liquid diet, liquid oral supplementations, and then next day patient was okay. Then next day we start soft oral trial.
Okay. Good, Pooja. So normally we, in case of dysphagia concern, we normally do not start with clear liquid. But anyway, it's good that you have involved the speech therapist also. Good.
Yes, ma'am. We involved speech therapist because he's a pediatric patient, and first cases and PNC is a extremely rare variant. Then we first day and to last day we include the speech therapist and intensivist also.
Thank you, Pooja.
Thank you so much, ma'am.
Pooja, I have one question for you.
Yes, ma'am.
You're from which place?
Ma'am, Indore.
Indore. Okay, okay. And can you just tell me a little bit more about the age category of the patient?
Ma'am, my patient was 16 years old.
16 years old. Okay, okay, fine. So you have given around 2,000 calories and 87 grams of protein.
Yes, ma'am.
Was he on physiotherapy after he went home also?
Yes, ma'am.
Okay.
He went, he go home after discharge, speech therapy and physiotherapy also done 2 to 3 months. And nutritional supplementation, nutrition support, he followed back last 15 days back he come and reschedule his dietary changes.
You had reviewed it again.
Yes, ma'am. Yes, ma'am.
Dietary recommendation.
Yes, ma'am.
He was compliant with everything that you have given?
Yes, ma'am. And he's recovered well.
Okay. Okay, fine. Thank you. And I would emphasize the same points as what Vaidhi ma'am has, emphasized. You should not be giving the names of the supplements.
Okay.
And clear liquid is a no when a patient is in dysphagia.
Okay, ma'am.
Okay. All right. Thank you.
Yes, ma'am. Thank you.
Hi Pooja, this is Rajeshri here.
Yes, ma'am.
So I want to add the point what Sandhya and Vaidehi ma'am was telling about it. So whenever you're trying for a patient with Rhinestone and when there is a transition is happening, probably instead of giving a clear liquid, we can try some thick liquids or something like that. With the help of speech therapist, we can try it out. Not just like that, we can't try it out. Even that might end up with aspiration or something like that. Otherwise, the scientific formulas we can put it up rather than putting a specific formulas. We can avoid while presenting your PPTs or something like that.
Okay, ma'am.
Yeah, thank you.
Thank you, ma'am.
Are we moving to the next presentation?
All right, I'm speaking on mute. I'm sorry. We are moving on with our next presenter for today, Gayatri. Gayatri, are you ready?
Yes, ma'am. Am I
Okay.
audible?
Yeah. You are audible. Great. Sai, please share her presentation. Gayatri, please stick to your time. You have about 12 minutes. If you can just wrap it before that, that'll be great. We're already running out of time. Okay, and then we can
Okay,
take
ma'am.
questions. All right. Okay.
Okay, good afternoon, all. First of all, I would like to express my gratitude to the panel members and all the team to give me such an opportunity to present my case study in this wonderful platform. So, coming to the case presentation, today I would like to present my case study on the topic mixed burns. Next slide, please. So burns, a burn injury to the skin or other organic tissue is primarily caused by heat, radiation, radioactivity, electricity, friction, or contact with chemicals, as well as respiratory damage resulting from some inhalation are also considered to be burns. So burns are measured as a percentage of the total body area affected. According to that, there are certain categories of burns. First one is a superficial or first degree burn, which causes local inflammation of the skin or epidermis and are characterized by pain, redness, and mild edema. Next one is the partial thickness burns or second degree burns, which are deeper, involving the dermis, and in addition to the pain, redness, and inflammation. And there is also blistering of the skin. Third one is the full thickness burn or third degree burns, which are deeper, still involving loss of all layers of the skin and part of the underlying fat layer also. And here, because the nerves and blood vessels are damaged, third degree burns appear white and leathery and tend to be relatively painless. The last one is the subdermal or fourth degree burns, which result in tendons and bones to being exposed. Next slide. Oh, so coming to the patient profile, the patient was a 26-year-old male presented with a complaint of burns over the face and hand from a boiler. The medical diagnosis was mixed burns involving the right forearm, hand, right side face, ear, hair over the scalp, beard, and mustache. At the time of admission, the patient had a weight of 50 kg with 165 centimeter with a BMI of 18 kg per meter square. The ideal body weight for the patient according to Lemon's formula was 60 kg and the length of hospital stay was 13 days. The tool used for screening and assessment was subjective global assessment, which gives a score of A. And the patient during the treatment period, the patient had undergone tangential excision and split skin grafting. Next slide. So here is the biochemical parameters. All the biochemical parameters were normal except the sodium values. Initially, there was a slight variation in the sodium values, but it has returned to normal level during the hospital stay. Next is the medications. The medications given are injection cefuroxime, injection paracetamol, injection Pantop, injection tramadol, injection Emelset, and tab pregabalin and tab etoshide. Injection cefuroxime was an antibiotic and injection paracetamol is an analgesic and antipyretic agent. Injection Pantop was is a proton pump inhibitor and injection tramadol is an analgesic. Injection Emelset is an antiemetic agent and tab pregabalin is used to reduce the redness of reduce the release of certain chemicals in the central nervous system that release pain. And tab etoshine is a painkiller. And all of these medications have any other don't have any other interaction with the nutrients except the injection Pantop. Injection Pantop can cause to absorb less vitamin B12 and calcium than usual. Next slide, please. Next is the 24 hours home recall. From the home recall, it was understood that the patient had an average intake of 1,210 kilocalorie of energy, 162 grams of carbohydrate, 21 grams of protein, 41 grams of fat, and 26 grams of fiber. Here is the PER statement. The PER statement is inadequate protein intake related to increased demand for wound healing as evidenced by patient's medical history. Next slide, please. Here is the nutrient prescription, which is the modified RDA. The energy for the patient was calculated using the Curie formula, which is 25 into weight in kilogram plus 40 into total body surface area affected, which is equal to 1,600 kilocalorie. And 60% of the total calories should be made from carbohydrate, which is 240 gram. And 20% of the total calories should be made from protein, or 1.6 grams of protein can be given to the patient, that is equal to 80 grams of protein, and 20 grams of total calories should be made from fat, that is 35.5 grams, and 25 to 30 grams of fiber has given to the patient. The fluid requirement for the patient has calculated using Parkland formula, that is 4 ml into percentage of total body surface area affected into body weight in kilogram, that is equal to 1,600 ml. An input-output chart was not maintained since the patient's intake and output was adequate. Next is the nutrient intervention. The diet type designed for the patient was high-protein diet, and the short-term goals were to promote optimal wound healing and rapid recovery from burn injuries, to minimize the metabolic stress response, to restore and maintain fluid balance, and to minimize the risk of complications including infections during the treatment period. And the long-term goals were to maintain a reasonable weight to prevent weight loss, to attain and maintain normal nutritional status, and maintain lean body mass, to provide correct amount and mix of nutrients to limit or modulate the stress response. Next slide, please. Here is the diet progression during the hospital stay. On pre-operative day 1, the patient was on a normal diet. On preoperative day 2, the patient's normal diet has modified into a high-protein diet. On day 3, the patient was on NPO4, tangential excision and split skin grafting. From postoperative day 1 to 10, the patient was following a high-protein diet. Here is the summary of a hospital recall. The summary of hospital recall shows that the patient get an average of 1,468 kilocalories of energy, 174 grams of carbohydrate, 52 grams of protein, 43 grams of fat, and 29 grams of fiber. To improve the nutrient intake, the patient was supplemented with oral nutrition supplement. Next slide, please. Here is the comparison of the hospital diet. The hospital recall of 3 consecutive days has calculated here. From this graph, we can understand that the patient intake has improved day by day. Next slide, please. Is the prescribed diet, which is a high protein diet. In the prescribed diet, also the patient was supplemented with egg whites, oral nutrition supplement, and nutrient dense liquids with the added oral nutrition supplement. Next slide. From the prescribed diet, the patient will get 1,738 kilocalories, 240 grams of carbohydrate, 73 grams of protein, 39 grams of fat, and 30 grams of fiber. Next slide. Here is the comparison of the hospital diet and prescribed diet with the modified RDA. While comparing the hospital diet with the modified RDA, I got to know that due to the severe pain, inconvenience, and discomfort experienced by the patient due to the burns, it has negatively influenced his intake during the hospital stay. But from the prescribed diet, the patient has begin to get the actual amount of nutrients according to his requirement. Next slide, please. So in conclusion, the patient was a 26-year-old male presented with burns on his face and hand resulting from a boiler incident. He underwent tangential excision and split skin grafting as part of the treatment. And initially, the patient followed a normal diet, which is low in protein and high in fried foods. To support the healing process, a high protein diet was recommended. To meet nutrient requirements and to promote muscle mass recovery, oral nutrition supplement was initiated. And during hospitalization, the patient was advised to consume egg whites daily and supplemented with nutrient-dense liquids. To help with constipation, a soluble fiber-rich liquid was added to his diet. And upon the discharge, the patient was prescribed a high-protein diet and instructed to continue the recommended nutrition plan. The discharge weight was 52 kilogram, which shows a positive side of the treatment history and the diet which was given to the patient. So that's all about my case presentation. Hope all you understood. Thank you.
Wonderful, Gayatri. Thank you so much, and thanks for sticking to the time and making sure that you cover everything. That's very good and it's important. Jury members?
Thank you, ma'am.
Yep. If you have any questions for Gayatri, please go ahead.
Gayatri, very crisp presentation. Perfect. I think you have covered all the points. Only one thing, we always insist on the high protein, high calorie, but in case of burns, we also should be careful about the fluid because dehydration also can, there is dehydration first of all, and if fluid replacement does not happen gradually, we cannot even give suddenly also, then chances of delayed recovery are more. So that also should be considered. Otherwise, Gayatri, very nice.
Okay, ma'am. Thank you so much.
Hi, Gayatri. This is Sandhya here. The
Hi,
format of
ma'am.
your presentation was quite apt. So, you were able to elaborate everything, in a very structured manner. Thank you so much.
Okay, ma'am. Thank you so much.
I have one question for you. So, after how many days did you do the follow-up in this patient?
The follow-up for the patient was done every day, and for an interval of 1 day, the patient was supplemented with nutrient-dense liquid so that the patient was follow up each and every day during the hospital stay.
After the
And
patient went home?
after the discharge, the patient was followed up through the phone, and I have asked him how about the nutrient intake and the oral nutrition supplement which was given, and he was consuming that, and the dietary intake was overall good.
How many times a day you had given ONS?
2 times per day, ma'am.
Okay. And did you introduce the glutamine
No,
immunonutrition in this patient?
no, ma'am. No, ma'am. Actually, the patient's intake was apt for according to his requirement, so that glutamine supplementation was not at all needed because it was a minor burns. Only 8% of burns was there, and his there was no signs of dehydration. His intake and output was actually good, so that there shows no signs of glutamine supplementation there. So actually, it was healed through the treatment and the dietary part also.
Okay. All right. Thank you.
Thank you, ma'am. Thank you.
Hi, Gayatri. Nice presentation. I just wanted to ask you only one thing. Why do people have not maintained the IO chart? Is there anything specific? Because most of us, we will forget about the patients. Whenever you go to the bedside, when you ask about the fluid intake, probably they'll be having lesser than the what has been recommended. So is it anything specific that you have not been monitored or something like that? The IO chart.
About the chart, ma'am.
Yeah.
The input-output chart was maintained previously, but from that chart, it was got to know that his intake and output was adequate. Then after, we decided not to maintain that chart because he was taking that much amount of liquid and fluids in an daily basis. So that's why we have not introduced any kinds of that extra supplementation of liquids, but his intake output chart was not maintained after 2 to 3 days.
So how come you able to calculate the cal requirement then?
Fluid requirement was calculated using Parkland formula.
Oral intake, I'm asking about the oral intake. How you calculated the oral intake during the hospital stay?
Through recall, ma'am, I asked him about each and everything he has consumed during the hospital stay.
Okay, fine. And one more thing is, in your last slide, you were just mentioning about the high calorie and high protein with fried food items. So is it anything specific on that?
It was mentioned about the home recall, ma'am. At home, he was consuming that much amount of fried foods and high calorie items, but the actual nutrients, which is the protein and micronutrients, was absent in his diet, which was followed in home. That's why I have mentioned in the home recall, he was consuming high amount of fried foods. But when he got to admitted to the hospital, it was replaced with a high protein diet.
This is the home recall you have mentioned that. The last slide
Yes.
you mentioned was the home recall.
It's about the fried foods. It is based on the home recall, and the high protein diet was about the discharge diet.
Okay. And then any specific on the immune nutrient you have not focused on any immune nutrient or something like that?
No, ma'am, no.
No, you have not given. Okay, fine. So what the oral nutrition supplement you recommended? Is it anything specific?
High protein formula, ma'am. Can I share the company name?
No need, no need. I just wanted to know any specific, component you have given to them. That's what we just want.
Actually, it was a high protein formula, and it was given twice a day, and he was consuming that, and it has showed the signs of healing also.
Okay, fine. Thank you.
Okay.
Thank you.
Thank you. Thank you.
All right. I think we are through with our questions from the jury members as well. Thank you so much, Gayatri. That was wonderful presentation again, and that concludes our presentations for today. Thank you so much to all the jury members for taking time and being with us today and guiding these young nutritionists. And thank you all the presenters for coming prepared and presenting your case studies. Thank you, Pulse, for sponsoring this event and for the effort to get the best out of the nutrition professionals and encourage these young nutritionists in their beginning of their careers. It's a wonderful initiative by Pulse. I would like to appreciate the Pulse team for that. This concludes our webinar for today. And the certificates for the quiz that we have conducted will be announced on social media, and our team will be in touch to send those certificates out to you. Thank you again, and we will see you in another case study presentations next month.
Thank
Bye.
you. Bye.
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 Bye. Bye. Thank you.
Thanks, everyone.